Sigue en sintonía de nuestra programación.
Está empezando el show del doctor Roy Aranda, donde abordaremos temas sobre separación niños de padres, casos de violencia, traumas con los indocumentados, cómo resistir ante tiempos de pandemias. Llámanos en vivo al 1-888-900-2811, extensión 6, y haz tus propias preguntas al aire. ¡Comenzamos!
Good evening, dear Tribuna TV viewers. Buenas noches, queridos televidentes de la famosísima Tribuna TV. Today is November 17, 2022. Hoy estamos a noviembre 17, 2022. It's hard to believe we're 1 week away from Thanksgiving. The time flies. I mean, it's amazing. One more week, we're in Thanksgiving, and then next month we'll be hosting a show on dealing and coping with holiday blues. You know, not everybody's cheerful during the holidays. So tendremos la acción de gracia próximo jueves. Y después de eso estamos ya en la despedida del año y la época navideña. So, vamos a tener un show. So just to let the viewers know, para que sepan todos los televidentes, the show is being recorded live on YouTube, and there will be a recording available tomorrow on Tribuna TV, Facebook, and other platforms. Se está grabando actualmente en YouTube. Mañana estará disponible en Tribuna TV, Facebook, y en otras plataformas. The show for today, it's what I consider to be a very important show based on the topic and the likely exposure that all our viewers have had or would have had to this particular topic, namely coping with personal injury, physical medicine and rehabilitation, and psychological recovery. I have as a guest a wonderful physician, a physiatrist, not to be confused with psychiatrist, a physiatrist, Dr. Raj B. Tolat, MD, MBA, and my consultant, I always give him a shout out, Dr. Peter Canaris, who's been with me ever since show number 1. I'm four years and about 3 months into doing this show. I believe that today is the 81st show. Hoy es el show número 81. So without further ado, let me just introduce the topic and then our guests, and we'll move into the educational components of this particular show, okay? Oscar, si quieres saludar a los televidentes. Oscar's my producer. I always acknowledge him. He's the magic behind the production and putting everything up. Don Oscar, have a happy and safe Thanksgiving. I've been waiting for 4 years for some Thanksgiving pupusas. Maybe this Thursday. Maybe this Thursday I'll get some Thanksgiving pupusas. So gracias, Oscar. Oscar again, the magician behind the show. So, ¿me puede poner el primer slide, Oscar? Okay, so here you see the name, the title, Coping with Personal Injury, Physical Medicine and Rehabilitation, and Psychological Recovery. This is what I meant by saying that I have to believe that every viewer in some way has been impacted, if not personally, knows somebody who has been affected by some form of a personal injury. The sheer number of injuries every year, 31 million, is eye-opening. Approximately 2 million are severe enough to require hospitalization. 162,000 are fatal. Traffic accidents are the most prevalent, the most common, approximately 5.5 million annually, resulting in 3 million injuries and approximately 40,000 fatalities. Dr. Tolat, who I will introduce momentarily, I will bring up to you that I did my doctoral dissertation long time ago. I defended my dissertation in 1983, and it dealt with traffic accidents and cognitive behavioral therapy treatment approaches towards dealing with these kinds of traffic accidents. And I have to tell you, the numbers have remained consistent. You know, we have improved vehicles, we have GPSs, we have wonderful mirrors, we have cameras all over the car, cars that brake by themselves. It's amazing, but the numbers seem to stay constant every year. It's just something. Obviously, it has to be a human factor, because the road conditions also have improved. So we're really dealing with a human factor that is very stable, consistent, prevalent, and something that we really need to focus on. Occupational injuries are very prevalent. About 4.6 million people require medical treatment for job-related injuries every year. A little bit under 5,000 workers died on the job in 2020. I will also add that as a statistic, I am reasonably sure that not only this, but the number of traffic accidents is underrepresented. Not everybody reports, not everyone files a complaint for workers' compensation, not everybody takes their accident and reports it. Sometimes they just settle it off, they make an agreement and they settle it out on the street or among themselves. You don't have everything necessarily reported. It's likely an underestimation. My guest, Dr. Raj Tolat, who I will introduce momentarily, is a physician who specializes in physical medicine and rehabilitation, physiatry. Currently owns 3 physical medicine and rehabilitation practices in Valley Stream, Medford, and Belrose. Valley Stream and Belrose are in Queens. Medford is in Suffolk. Dr. Tolat and I will talk about the medical and psychological consequences of personal injuries and focus on treatment and recovery. We have several informative slides. I encourage my viewers to either take photos of the slides so that you can look them over later, and or wait for the recording and you can take screenshots. Okay, it's my intent and Dr. Tolat's intent that these slides are educational, informative, and not for you to memorize them as we go through them. So it's a reference, a resource for you to use as needed down the road. This show, I'm dedicating it to all victims of personal injuries. Por favor, Oscar, si me puede poner el slide número 2. So this is Dr. Tolat, and he's a physician, specializes in physical medicine rehabilitation. He graduated from the Mount Sinai School of Medicine in 1996, completed his residency training at Long Island Jewish Medical Center, that's LIJ, in 2000. He then completed a master's in business administration with a focus in healthcare management in 2005. No wonder he's able to be a very adept practitioner, physician, but also super competent businessman. You need to have, for a practice to be successful, you've got to have exposure. You've got to have something that meets the needs of the patient, and of course, you have to have good treaters. People that provide the treatment. He was from 2008 to 2008. He was full-time faculty at North Shore LIJ, residency program director from 2005 to 2008. So he held very high-level training positions. He left North Shore LIJ to pursue private practice, and as I mentioned before, he owns 3 physical medicine rehabilitation practices in Valley Stream, Medford, and Belrose. So I am delighted for the second slide to have Dr. Tolat, who I've known for several years. I confess, I've known him and have had some interactions with him professionally for a few years. And I was delighted when he jumped at the opportunity to do this type of show that I thought was, waiting for quite a while to actually put it out there. Something that we're really focusing heavily on the physician perspective. So, Dr. Tolat, welcome. Just if you'd like to greet the viewers and maybe add a word or two. Obviously what I said about you is very brief.
Well, first of all, thank you, Dr. Aranda, for inviting me onto your program. And I want to thank all the viewers that are watching tonight for joining us. I certainly hope that the physical medicine and rehabilitation aspect of these injuries will be very educational for our audience tonight. And the interplay between PM&R and psychology will also will shed some more light onto the multidisciplinary nature of how to treat these injuries. I'm looking forward to a very exciting hour coming up.
Great, thank you. We're going to be focusing on some common types of injuries. I mentioned traffic accidents and occupational injuries. There are many, many more. We'll focus on the types of injuries that occur, not just the source of the injury, but what body part is affected or injured, the type of injury itself, and then we'll also get into a focus on what Dr. Tolat provides. Like we'll hear his his wisdom in this particular area, because there's a lot. I mean, we have, he is the most likely the PMR doctor, the physical medicine rehabilitation is your first line. That's most likely where the patients will be referred to, or an attorney will recommend it, or a treating doctor or a hospital will initiate a referral, or give several possible referral sources. But your PMR doctor, your physiatrist, is the first line. Sort of like the really like more like the general of what's going on, because the physiatrist is the person that will cover all aspects of the treatment needs of the patient and make appropriate referrals, obviously to neurologists, orthopedists, etc. What I do as a psychologist, many times I think of myself as a quarterback. Because I'm going to be getting information from referrals, and then I contact and go to the referral source, where I connect and communicate with other specialists. So I'm sort of quarterbacking the patient's needs. Patients also often are getting so many different sources of information, they become confused. They don't know, oh my God, injections, or possibility of surgery, or something about these electrodes being put into me that I don't understand, or electrodes being put into me. And I offer a bit of an educational role when that happens. So without further ado, Oscar, por favor, let's look at some of the common causes of injuries. Por favor, Oscar, el número 4. Oh, common injuries is 3. That's why I need Oscar. Okay. Well, I mentioned traffic accidents, occupational injuries. We have a lot more. And I don't pretend that this list that I have given you exhausts and covers everything under the planet. But I think I've given you a good summary. Slip and fall accidents, bicycle injuries, pedestrians, transportation accidents. I have often dealt with victims of railroad accidents, either on the train or, God forbid, tracks, boating accidents, busing injuries, airline injuries, and there's others. Obviously, there's other kinds of transportation accidents. Sports injuries, they're very prevalent. I'm going to ask Dr. Tolat when I put the slide down. Crime victims, of course, assaults, domestic violence, abuse, sexual assaults, victims of neglect. If you've watched my shows, you know that I did a show last week on child abuse and neglect, and it was pretty much to highlight the situation that took place with Thomas Balva. I've also done shows on domestic violence. So obviously, these are crime victims. Medical malpractice, product liability. You may put something on it before you know it. You have a rash, you have skin burns, you have, the burns could become horrible. Yeah, it could be with some patients can be pretty bad. Animal attacks. So, por favor, puedes sacar a slide. Raj, anything you'd like to comment on that? I hope you don't mind if I call you by first name.
No, absolutely, and of course, no, I'm very formal.
Or anything to say about the different kinds?
This is actually quite a complete list. Yeah, this is quite a complete list. And I'll talk a little bit more when my slides come up in a little bit. But traffic accidents and occupational injuries are by far 1 and 2 on our list of what we see as far as the most common injuries or most common sources of injuries. Sports injuries is right up there as well. And in fact, we have specialists in our field that do fellowship just to deal with sports injuries. So that's how common that is. But this is a very, very exhaustive list and a quite a complete list.
And with sports injuries, like the role the psychologists have is different. When we work with somebody who is injured in a car accident, they may become driving phobic, afraid to be out on the street, afraid to cross streets. When you're dealing with a sports injury, the person may be afraid to perform, may be afraid to go back to doing the sport, may feel guilty that he or she did something wrong or let a team member down. So there's a different aspect there. You have to work with the person injured in sports in terms of overcoming possible guilt feelings, questions of inferiority or having failed in some way, and then having them also develop visualization skills so they can visualize themselves, for instance, in tennis, hitting the racket appropriately, properly, coming up to the net, different kinds of things. I didn't want to belabor it, but I do want to point out that different kinds of injuries and interface with occupational therapy, physical therapy, there's different goals, different objectives. I have, incidentally, the last category that was up there was animal attacks, and I have had quite a few of them in the context of dealing with postal workers. They'll come to the door like a dog may not be properly restrained or loose, or the moment they open up the gate, the dog is not restrained, and they sustain an injury or a bite. I've had other injuries, postal workers slipping on ice and things like that, but it's not that uncommon for the animal attacks, and then having to deal with that kind of a phobic reaction and how they come back to it. Let's look now at slide 4, common causes of injuries. Por favor, el 4, Oscar. So here we see slips and falls, slips and trips, same thing, falls, bending, overexertion. Well, tripping is not the same as falling. You can slip and fall, and you can also trip and fall. So tripping is you're tripping over a rug or over a step or over a crack in the sidewalk. A slip is something, like a coffee stain or a spill on aisle 3 that wasn't cleaned up, and you slip on it, and as a result of it, you fall. And then the fall, of course, is going to have a lot to do with the type of treatment that you need. Did you land on your right shoulder, on your right hip, on your left side? Did you fall forwards and hurt your knees? Did you fall not standing, but kneeling? Did you fall backwards and smack your head? There's different body parts. Bending, overexertions, pushing as opposed to pulling. They are not the same. Hitting or bumping into something. Repetitive use. And I get a lot of cordon machinery, and unfortunately, Raj, with the cordon machinery, often I get finger amputations and other partial limbs, and even I've had more than that, leg amputations and arm amputations in industrial accidents. Yeah. Puedes sacar a slide. Raj, any of these in particular you tend to see more often, or commentary in terms of how the treatment might be modified the way I suggested, depending on the type of injury?
Yeah, we tend to see, a lot of slips and trips coming up, like you mentioned in grocery stores or pharmacies. We also tend to see a lot more slips during the winter months when people are out and there's icy conditions on the road. So some of these can also be seasonal in terms of how commonly we see them. Overexertion, pushing, pulling, a lot of that can also be due to work-related injuries and the type of injuries that we see. So if we see nurses that are pulling or pushing patients that are repositioning them in bed, a lot of those bending, overexertion, pushing, pulling that you mentioned are often tied into occupational or work-related injuries as well.
I wanted to bring to the viewers' attention and have you comment if you agree. But we're moving into. I mean, I've been following the weather forecast, and I know that parts of the Northeast now are either under snow watch or already having snow. Right. And it's my understanding that here in New York, Buffalo's supposed to, if not already, supposed to get snow. And there's chances that even out here, my patients are telling me we're on a possible snow or snow rain kind of alert. What I wanted to mention to the viewers, and I'd like to ask you if you agree from your experience, is that in general, my sense is that whenever we have the first snowfall of the year, snow plus water or just snow or icy water, that first one, that your drivers and people, pedestrians, they're sort of like not used to it because it's been a year or 9 months since they had it, and that my sense is that it's a greater risk because the driver may not be slowing down to accommodate, may not be that wary of it. The pedestrian may just walk as usual and not feel the need to hold on or check with the foot first if it's slippery. I don't have statistics to prove this. It's an impression that I have based on years and years of being in the field. I don't know if you would agree with that.
Yeah, I think there is some truth to that, where we sort of get used to certain conditions, and when we get used to spring, summer, and fall, all of a sudden, once December, January hits, and you have that first sort of difficult day out weather-wise, I think some of that guard is let down because we're just not used to it for a number of months. The other interesting thing is that we always say that when there's a foot of snow, we don't really see too many slips and trips or motor vehicle accidents because people don't go out. But the dangerous part is when you see that 1 inch of snow or the sleet or freezing rain type of conditions where people will still go out and go about their business. That's when the majority of these slips and trips happen or motor vehicle accidents occur because people are still out going about their business. When it's a foot of snow, like what they're expecting in Buffalo this weekend, things shut down and nobody leaves their house. So you don't see those injuries as much.
Right. This is not too dissimilar to the fact that a lot of people around this time of the year, with the temperature, we had 70s like a couple of days ago, and now it's like low 30s.
Right.
When you have that 40-degree change in weather and drops and windy and rainy, people don't know how to dress. They're not used to it. They don't have that hardening effect.
Yeah.
In terms of going out, so of course they get sick. They also, you have the allergies. They get bad colds. There's exposure to flu season now, which is supposed to be, I think, the worst flu season, and I don't know how long. We still have COVID that's very prevalent out there, and unfortunately, when people are sniffling and coughing, one of the things that you always have to think is the possibility of COVID and having yourself checked, especially if there's some sort of fever. But I tend to see this a lot. Many of my patients are complaining to me that they have colds. Some of them are also that they first tested negative for COVID, but a few days later tested positive. And I just wanted to bring to the attention of the viewers that this is not an unusual thing, because the incubation for COVID could be 5 days, could be longer, could be a little bit quicker, depending on the strain, could be longer. So you could have a negative test and 3 days later it's positive. So let's look now at some of the common types of injuries, and then I'll ask Oscar to put it down and ask you again, based on your practice, what you tend to see a little bit more. Oscar, por favor, el 5. So these are some common types of injuries: cuts, lacerations, punctures. A puncture is not the same as a laceration or a cut. Sprains, strains that are not the same, nor are tears, musculoskeletal injuries, bruises, contusions, fractures, and amputations. Puedes sacar a slide. Raj, anything to comment on those common types of injuries, and if some are a little bit more prevalent than others?
Yeah, I'm going to speak just in terms of my personal practice. I tend to see a lot of the sprain strains, whether it be lumbar, low back, cervical or neck sprains, shoulders, knees, probably in that order of prevalence. That kind of gets tied into these musculoskeletal injuries. The cuts, lacerations, punctures, most of those people will initially seek treatment either in the ER of a hospital or at an urgent care facility and have that addressed there in a far more acute setting. In my personal practice, I tend to see more of the musculoskeletal injuries, including the sprain strains and soft tissue injuries. Some bruises and contusions. Fractures, again, they tend to be in the ER first or an urgent care facility, and tend to see the orthopedist first before they come see us. And amputations, of course, less likely. I do like to point out that in my last life and my career at LIJ, I did have a weekly amputee clinic where we prescribed prosthetics and actually manufactured prosthetics for the amputees, but it's certainly not as common, and it's certainly not a big part of my current practice.
But even that is something that's not so necessarily cut in stone, because you're dealing with things like the limb shrinking. Yeah. There may be an overextension of the bone, and you may need further surgical interventions, refitting, new prosthetics. So
phantom
that
pain
is a big psychological
right?
component.
Yeah, phantom pain sensations as well is a big thing in terms of pain management. Absolutely.
Yeah, and then of course the insurance company not being necessarily too thrilled for a new prosthetic every 2 years.
Right.
It's not that easy. So Raj, we're moving into your slides that you were gracious enough to provide. So I'm gonna, you'll be the main presenter going forward. Por favor, Oscar, el número 7. So slide 7, this is basically just an overview of physical medicine rehabilitation. Here you see Dr. Raj Tolat's name, degrees, and his office location. Okay, physical medicine and rehabilitation, and Premier East Physical Medicine and Rehabilitation. So puede sacar el slide. Por favor, el número 8. So Raj, feel free to read this and comment on it, and then when you're done, I'll ask Oscar to take it down, and if I have any commentary, I'll make it then.
Right. Well, some of this is a little repetitious. I do know that you addressed some of this in your opening as well, Dr. Aranda. So, but we did talk about the fact that there were 31 million people injured in the U.S. every year requiring medical treatment. That includes 2 million hospitalizations, over 160,000 fatalities. And of those, the leading causes are motor vehicle accidents and work-related injuries. And that's what I had mentioned a few minutes ago, that by far, those are the number 1 and 2 most common causes of injuries that we see. In terms of motor vehicle accidents, we look at 5.5 million MVAs per year, accounting for 3 million injuries and 40,000 fatalities. These are not insignificant numbers. And like you had mentioned earlier, despite all the advances we have made in terms of car safety, these numbers are quite stable over a number of years. In terms of work-related injuries, over 4.5 million require medical treatment. Workers' compensation injuries are a significant part of outpatient musculoskeletal practice. At the same time, time lost from work is a huge financial burden to our society. And one of the roles of the physiatrist is not only to treat these work-related injured patients, but also to safely get them back and working so that they can continue their life as they'd had prior to this injury, and we minimize the economic impact of these work-related injuries as well. Construction site injuries by far are the most common and the most complicated of patients, just because of the potential multi-trauma nature of those types of injuries. But again, work-related injuries are not necessarily people that, construction workers that fall off a scaffolding. We also see the other end of the spectrum, where we see secretaries that come in with carpal tunnel syndrome because of repetitive use or repetitive strain injuries. But that's their life, that's their livelihood. That's what they have to do to earn a living. And so our goal is to treat them effectively, efficiently, quickly, completely, and ultimately get them back to work for their own livelihood purposes, but also for the vast majority of the companies that are out there, as well as for the economy as a whole.
Okay. Oscar, ¿puedes sacar el número 7? No, pero saca el 7, no pongas el 8 todavía. Oh, no, si saca el 8, sí. So I wanted to ask you, well, I wanted to point one thing out. There are times that you get sort of like an overlap. I mean, I've had situations where an employee at work had to drive to deliver something, and in the process of delivering, and or an ambulance driver, from the hospital transporting a patient is in an accident.
Right.
So you're dealing with occupational, but you're also dealing with, the consequences of the motor vehicle accident and the anxiety of being on the road and things like that. And it becomes a bit complicated when you're dealing with insurance companies and they're saying, what does that have to do with the type of work that this person does? It can be a little bit messy. The other thing that I wanted to ask you, we've been dealing with COVID-19 since ballpark March of 2020. Now, even though presumably everything has reopened and so forth, and people are out on the roads and much more face-to-face contact than before, even though I still caution all my patients to wear a mask and engage in proper precautions. For quite a period of time, there was obviously fewer cars on the road, less driving, fewer people working and or working from home. Did you see changes in the type of presentations that you had? Did you see more COVID related kinds of people who were exposed and had COVID, and as a result of that we're now having occupational claims as a result? Did it modify for you is my question.
Well, the first thing we saw was we definitely saw a decrease across all types of injuries, especially motor vehicle accidents, because there were less people on the road. There's just less volume on the road, so less chance of getting into an accident. So we definitely saw less in terms of motor vehicle accidents. With people working remotely, we also saw less work-related injuries. People were able to work from home and not necessarily have a work-related slip and fall or a work-related motor vehicle accident. So we saw a downturn in that as well. As far as COVID-related injuries or COVID-related illness and rehabilitation sequelae after that, personally, we did not see as much, and that's probably because of the nature of my practice, which is really more outpatient musculoskeletal rehabilitation. But I do know that there was definitely a huge upsurge in COVID-related rehabilitation treatment necessary, more so in acute rehabilitation hospitals, acute rehab facilities, skilled nursing facilities, subacute or nursing home-based rehab. So they really saw a far more of an increase in COVID-related rehabilitation issues than we do as an outpatient musculoskeletal practice.
Okay. Have you experienced what many of my patients are telling me, that they're on the road, maybe for the past ballpark 2-ish or so months, pretty much, with the BA.5 COVID-19 variant, people were scared to death because it was supposedly 30 seconds to get contaminated. But those that were driving, my patients were telling me, so this goes back to just a few months, that their perception is that drivers are crazy. Some of the expressions they say, they're crazy. They're seeing aggressive drivers, more speeding, they come closer. I personally don't see it. I'm not out that often, but I'm hearing it from my patients. Is that sort of like a thread you're getting? Is there greater aggression now in drivers?
I don't know if there's greater aggression in drivers. I think there's always been that aggression. And again, it only takes one aggressive driver to cause potentially multiple motor vehicle accidents. So, we've always seen that sort of road rage or aggressive drivers, the ones that are feel that they're infallible and nothing's going to happen to them. We've seen that historically. I've been doing this now for close to about 15 years, a little over 15 years, and I don't feel that COVID in and of itself has changed that sort of personality type at all. Whether or not there's more of them out there or not, I don't know. But I certainly know that there are still enough of them out there, and historically we've seen enough of them over all these years.
From a psychological standpoint, it would occur to me as a possibility that there's been frustration, loss of income, annoyances at home, increased not only financial distress, but increased stressors in family life. So, people, take this out on the road.
Yeah.
So
yeah.
that would be my rationale as a basis for how there might be a psychological consequence to something like this. Okay, so por favor, Oscar, pon y mantén el slide número 9 hasta que te lo diga que te lo quitas. Okay. Slide 9. So, Raj, tell us what we're seeing here.
Yeah.
And tell us what that lovely young lady is doing on the carpet.
So I'm going to first just offer an overview of what physical medicine and rehabilitation is, because though it is a specialty that has been around for decades and decades, it's still one of the newer specialties in medicine. Everybody knows what a cardiologist does. Everyone knows what a GI doctor does. Everyone knows what an orthopedic surgeon does. Not everyone knows what a physical medicine and rehabilitation specialist does. And like you said, I am a physiatrist, so I will use the terms physical medicine and rehabilitation, PM&R, and physiatry interchangeably because they do represent one and the same thing. So as a physiatrist, I still get patients or colleagues or family members or friends asking, so you're a physicist? No, I've gotten a physicist, I've gotten a psychiatrist, I've gotten a podiatrist, but a physiatrist is a specialist in physical medicine and rehabilitation. And to just sort of lay the groundwork of what makes us different as a specialty compared to, any of the other medical specialties is we talk about disease, impairment, disability, and handicap. And just to give you an example of, let's say we take a patient that has a stroke. Their disease is really, let's say, a left-sided middle cerebral artery occlusion that causes their stroke. The impairment is how that disease impacts their bodily functions. So a left-sided stroke can cause right arm weakness. It can cause right leg weakness. It can cause problems with speech and language. Those are all the impairments that a person has secondary to their disease. A disability is how that disease and impairment then affect the individual as a person. And so right arm weakness may give them difficulties with their ability to perform their activities of daily living, which are things like dressing, bathing, grooming, personal hygiene. Right leg weakness can impact their ability to ambulate. So they're not able to walk, either be indoors, outdoors, going up and down stairs. Those are all disabilities. So it's really the impact of disease, which is at the cellular level, the impairment being the organ system level, and then the disability being at the whole person level. And then finally, there's the handicap, which is how that disability of that particular individual affects them in a broader societal context. So they are unable to travel to and from work. They are unable to perform their work-related activities. They're unable to play the guitar because that's what they did before. So it really encompasses their both vocational and avocational interests, as well as their broader role in society. They're unable to be, a functioning husband or wife or father or mother. That all represents the handicap. So where we step in is not so much so the disease level, where a neurologist may actually treat the stroke itself, but physical medicine and rehabilitation specialists really intervene more at the impairment, the disability, and the handicap level. And so we really focus on function, which is not necessarily the patient's pain or muscle strength or sensory abilities. While all of that is important and we do treat those, our real focus is on restoring a patient to their normal function, or as normal a function as they can have based on what their disease or impairment or disability is. And in order to focus on function, we use a multidisciplinary approach. And I've outlined here sort of a multidisciplinary treatment approach that we use within our own specialty. And on the next slide, I'll talk about a multidisciplinary treatment approach with encompassing other specialties. But within our specialty, we utilize rehabilitation nursing, especially in an inpatient rehabilitation setting. But we have very close associations, and we work together with physical therapists, occupational therapists, speech and language therapists, recreational therapists, those that, like I mentioned, to get the patient back to their avocational interests, vocational training to work on getting them back to whatever their job was prior, or to find them a job setting that is appropriate for them, or that is something that they can do at this point in time, given what their disease and impairment is. We utilize social workers as well. We interplay a lot with social workers to figure out what the patient's needs are after an acute event, whether it be in an inpatient rehab setting, an outpatient rehab setting. Do they need to go to a nursing home or a skilled nursing facility? Or if they're able to go home, what resources do they need at home to be able to function? And then finally, we will also interplay with psychologists and neuropsychologists for especially patients that have had cognitive impairment after a particular event takes place, such as a stroke. We interplay with psychologists in an outpatient setting greatly because of patients that have been injured in a motor vehicle accident that now have anxiety and nervousness when they get behind a car, get behind the wheel, I should say. We interplay with psychologists for those that all of a sudden now have had a major event occur in their life that has altered the balance of their life, and now have either post-traumatic depression or post-traumatic anxiety. These are things that they need to work on, because in terms of treating the patient as a whole, we not only need to treat their physical aspects of their illness, but their mental and psychological aspects as well, which are so crucial to recovery.
Great. Oscar, por favor, puedes sacar 9. You can take 9 down. I'll have a few questions to ask you later on when we get into treatment. But before we put the next slide, I wanted to ask you something, because I see this often enough, and I know that that the insurance companies tend to deny it, and at depositions and things like that, on cross, it tends to be denied or minimized. But very often, as an example, somebody who has a problem with the right leg has to use a cane on the left side, the contralateral side, and starts to develop aches and pains in the left shoulder, or because you had an injury to the right arm, you're relying more on the left arm because you're favoring the right arm, and as a result of that, now you begin to have problems with the left arm. And to me, I see this as certainly, consequential to an injury. I don't know. I'm guessing you probably pick up on it fairly often, but I did want to bring up on that sometimes things can get a little bit muddier and more complicated, and even patients will be very upset and they don't understand why. I've also had patients use the cane on the wrong side.
Right. Or the wrong height of the cane, right? You certainly use the right word there, consequential. That was the key word. And that is the word that we use as well if we are trying to, what we call, quote, establish another body part to treat. And yes, you're right. It can get very muddy, and it can become a bit of a tug of war with the insurance companies to establish a new body part after the initial body parts have already been established and have been treated. I always tell my patients that our goal is always, let's say, if they do have a right arm issue and they've developed left arm issues secondary to overuse because of their inability to use the right, We say our goal is let's get that right arm better so you're able to utilize the right arm as you were prior to this injury, if in fact that is a possibility. And when we are able to accomplish that, you'll have to do less with your left arm and you won't need to overuse that left arm, and that left arm will on its own get better. Now, is that always the case? No, absolutely not. And that's why establishing that consequential injury to the other part and being able to treat that other part simultaneously is so crucial. But you are 100% correct that it's not always the easiest thing to do.
There's often an over reliance on the cane or assistive device to the point that it's detrimental, because you also want to get people to do some exercise and some movement.
Right.
So I know that at times it becomes almost like a behavioral addiction. I have to have my cane. I have to have my cane. I can't do anything without it.
Right, right. And the same holds true with even braces as well. I get a lot of patients that come in that say, "Oh, I'm having some back pain. I want to wear. Can you get me a back brace so I can wear that brace, during the day or at night?" And and I always tell them that if there is no structural instability that requires a brace, I'd rather you not wear the brace, because it's really doing the opposite of what we're trying to do in physical therapy, which is to get those muscles more mobile, to get better range of motion, and to get those muscles stronger. And if it is just a muscular soft tissue injury, the brace sometimes can actually be counterproductive because it impedes that movement of those muscles and soft tissues and ultimately can make those weaker, stiffer, and in the long run, potentially even more painful.
Similarly, medication can be a problem. There can be over-reliance on medication. There can be a cocktail of medications. There can be non-compliance with the number of hours. Don't take 8 hours, and people then are taking it. I take it as needed, and maybe as needed isn't the best way to take it. With the opioids, obviously, it's a major problem. But people are able to develop, psychological as well as physical dependencies. And I think, and correct me if I'm wrong, but I think that probably the best thought or the best approach is that it's okay to experience some pain. After all, having pain is not a bad thing, because it gives you information. It gives you information about something's going on with your body that you may need to tell the doctor or be aware of, and not overdo something if you have pain. And similarly, if you have you have some pain, taking medication to cope with severe pain, like on a scale of 0 to 10. We psychologists, and I know that physicians, where 10 is astronomical pain, and an 8 would be very severe, 9 is so close to catastrophic. I tend to see often 7s. I aim for 5s, somewhere in that area. But hopefully you would want a patient to minimize the reliance on medication and have some sort of pain, do some sort of structured exercise with the assistance of the physiatrist and physical therapist, and grin and bear it a little bit.
Yeah, absolutely. I agree. The medications do have a role in terms of alleviating pain, and hopefully once that pain is under good control, and again, I don't use the term that pain is eliminated, but under good control, like you said, we look at maybe a 3, a 4, or 5 on a pain scale, but rather than an 8, 9, or 10, elimination of pain may not even be a reasonable goal. But if we're able to control that pain and allow them then to be able to participate in a physical therapy program and get back to doing their functional activities, during that period of time, medications can play a positive role. And especially things like anti-inflammatory medications, muscle relaxants, those are very helpful in the acute setting. But once their pain is under good control, we tend to taper off the medications and really engage them in an active physical therapy program to be able to get them back to to the activities that they were doing prior to a particular injury or accident.
All right, let's look at the next slide. Oscar, por favor, número 10. And before I ask you on this, the slide before had the picture of that young lady doing an exercise on a mat. I assume that was physical therapy.
That was definitely some physical therapy and balance exercises.
Okay. All right. So take it away on slide number 10, Rush, please.
So as I had mentioned earlier, we do look at things a little bit differently as a physiatrist than, let's say, some other medical specialties like neurologists or internists or cardiologists. Our focus is really on the musculoskeletal system and the neurological systems, and oftentimes an interplay between the two. There's an old saying that says that physical medicine is sort of the musculoskeletal portion of PM&R, and rehabilitation is more of the neurological based illnesses that we see. So it's a little bit of an oversimplification, but there is some truth to that generalization. Again, as I said, we want to treat the patient as a whole. We are not necessarily treating just one body part or two body parts. When a patient comes in with a shoulder issue, if they have a rotator cuff tear and they are in pain and they have limited range of motion in that dominant arm, we are not looking to treat the shoulder only. We're looking to treat that patient as a whole. Obviously, the shoulder is our focus of treatment, but we are looking to see how does that shoulder injury impact them on a day-to-day basis, whether it be their ability to perform their work, their ability to dress and bathe, their ability to play catch with their kids. We have to take the patient as a person and treat them as a whole and see how this particular, again, I go back to the original terms of disease and impairment, how does that impact them and how does that cause their disability? And that's where we intervene. I did mention on my previous slide that we use a multidisciplinary approach to treatment. And we do that not only within our specialty, with physical therapists, occupational therapists, speech therapists, that whole list that I had provided earlier, but we do it in terms of being sort of, and you used this term earlier, being sort of almost the quarterback. We like to kind of be the quarterback of not only our team internally, but really the quarterback to coordinate care amongst other specialties as well. And I have a list here of sort of the specialties that we interface with most commonly. Obviously, orthopedic surgeries. Now, we tend to see patients before the orthopedist sees them. Oftentimes, if they come in after a motor vehicle accident or a work-related injury and they have a shoulder issue, they may go through a program of physical therapy, oral medications. We may do a steroid injection treatment potentially. And if all of that fails, we do have them see the orthopedist, because if they have a rotator cuff tear or a labrum tear, they may need surgery, and that may be the only option for them to actually get better. And then, of course, we would see the patient after the surgical procedure for postoperative physical therapy. So orthopedic surgeons are definitely the one specialty that we interface with most commonly. Vascular surgery, we talked a little bit earlier about amputees, but patients that have had bypass surgeries or amputations through a vascular surgeon, we will see those patients for postoperative rehabilitation as well. Plastic surgeons, we will see patients that have been that have had certain wounds or certain burns that need post-injury rehabilitation. Neurologists, especially from the standpoint of rehabilitation goes, neurologists are important, whether it be stroke-related post-rehabilitation, traumatic brain injury, spinal cord injury. We interface a lot with pain management specialists, and oftentimes pain management specialists are physiatrists that have done additional training in pain management, where they are better suited to handling not only medication issues, but are specifically trained in interventional pain procedures, such as epidural steroid injections, facet injections, radiofrequency ablation, medial branch blocks, and then, of course, percutaneous discectomies as well. We also interface with spine surgeons, and similar to the orthopedic surgeons, we may see the patient before the spine surgeon does. If they come in with a neck or back issue and they have disc pathology or a radiculopathy, which is a pinched nerve, we may offer them a program of physical therapy, again, medications, injections, and if that doesn't work, and if surgery is a last resort, they will see the spine surgeon, undergo surgery, and then we'll see them afterwards for post-surgical rehabilitation. And again, I go back to psychology, because not only is the physical aspects of a patient's disease, impairment, and disability important, but again, a major life event has occurred, and psychological intervention cannot be understated, whether it be to treat post-traumatic stress disorder, nervousness, anxiety, depression, any or all of those, again, goes into our treating the patient as a whole.
Oscar, puedes sacar el 10. So I just also wanted to to emphasize for the benefit of the viewers that there are different, just as there are different medications, there are different kinds of injection. Epidural is not the same as cortisone, and some of the nerve ablation, obviously that's different. And there's the manipulation under anesthesia. You didn't mention that, but I'm pretty sure that you're aware of it, and that you've seen it done. So there are these different kinds of procedures, and it would be up to the pain management specialist to discuss that with the patient. In terms of the surgery, there is typically a pre-surgical clearance. They have to go to physicians, and they may also require a cardiologist to clear something. And if somebody has a history of diabetes, they probably want clearance in terms of blood sugar levels. And quite often, you need to have COVID testing prior to the procedure as well. I always tell my patients prior to an approved procedure, I will also share with the patients that the fact that the doctor's telling you, I'm giving you a date on such and such a date, it's sort of tentative until and when you find that the insurance company has authorized it. And that authorization may not come until the patient is sent to one of the insurance company's doctors in what's called an IME. It's supposedly an independent medical examination, although frankly, I think that's a misnomer because I don't see anything independent about it. But you need to wait for the authorization. So assuming you have the authorization and everything's a green light, I'm always cautious about advising my patients to please limit outings and contact with other people. Last thing you want them to do is to get hurt again or to get sick, and then they're going to cancel the procedure. And who knows? It could be months down the road before you see it again. Por favor, el 11. I don't know if you had anything to comment on. I'm putting slide 11.
Yep. So to segue into the conditions that we see, and again, this was mentioned briefly earlier as well, but we see the musculoskeletal injuries that come about secondary to motor vehicle accidents, work-related injuries. Workers' compensation is a significant part of our practice. Sports-related injuries, and by sports-related injuries, that by no means, is relegated to professional athletes or only, Division I college athletes. We see sports-related injuries all the time in, what we call the weekend warriors, people that work their desk jobs Monday through Friday, and all of a sudden on Saturday and Sunday think that they're the next coming of LeBron James, and Monday mornings are always busy with those patients that have either sprained an ankle or hurt a shoulder or injured their knee playing basketball or football, whatever pickup games they do over the weekend. So sports-related injuries are a broad topic. And as mentioned earlier, we do have people in our field, not only physiatrists, but orthopedic surgeons as well, that do additional fellowship training specifically to treat just sports-related injuries. Obviously, post-surgical conditions, as far as orthopedics go, we will see patients that have undergone arthroscopic surgery, whether it be of the shoulder or the knee. Those are the most common, but we'll also see them at post-arthroscopy of the ankle or wrist. And of course, we see patients that have undergone more significant orthopedic procedures, such as total joint replacements, most commonly usually either the hip or the knee. We also see vascular, post-vascular surgery, whether it be bypass surgeries or, as we mentioned earlier, amputees, and then spine surgeries as well. And spine surgeries for both cervical or lumbar often also fall into a broad range of categories, from something as simple, and I use the term simple a little facetiously, because none of these surgeries are simple, but they can be more straightforward surgeries such as laminectomies, all the way up to discectomies and fusions as well. So we do see a lot of post-surgical patients as well. And as I mentioned earlier, oftentimes we'll see the patient preoperatively for rehabilitation, then they undergo the surgery, and then we'll see them postoperatively for additional rehabilitation. Slip and fall injuries we touched upon earlier as well, whether it be the cleanup on aisle 3 that Dr. Aranda mentioned earlier, whether they slip and fall on ice, especially as we get to the winter months now. Trip and falls on defective sidewalks, in apartment buildings that have defects on their stairs. We see a lot of those as well. We tend to see some neurologic conditions. I see less in my practice because it's more of an outpatient musculoskeletal practice, but definitely in a more academic setting, the neurologic conditions and rehabilitation as it relates to stroke, traumatic brain injury, and spinal cord injury, those conditions are seen in far greater frequency than you do in an outpatient musculoskeletal practice. We touched upon amputees earlier. We do see some of those. I don't see too many now in my practice, but amputees are a sort of a niche practice within physical medicine and rehabilitation. It's basically amputees work very closely with certified prosthetists and orthotists. Those are the people that basically manufacture and fabricate prostheses, which are artificial limbs, and or orthoses, which are basically braces. And then there's also a segment of physiatry that focuses on cardiac and pulmonary rehab. So it's rehabilitation for those patients that have undergone some sort of cardiac procedure, whether it be pacemaker placement, cardiac stents, cardiac bypass surgery. And the same, they also deal with patients that have undergone pulmonary procedure. So anything from as simple as, outpatient bronchoscopy all the way to lung transplants.
Okay. ¿Puedes sacar el slide, por favor, el 11? Before we get to 12, I just wanted also to point out that you could have multiple injuries, multiple body parts. So it's not that uncommon in a motor vehicle accident, even if you haven't had an actual, your head hasn't actually hit the steering wheel. Mostly somebody's a little bit short. If they hit anything at all going forward, it would be like the steering wheel. Very often with the going back and forth, the whiplash, they'll hit the headrest. You also have to understand the dynamics of the motor vehicle accident. Whether you go forward first or backward first. And there's this, it's called whiplash for a very good reason, because it's like a very, very harsh shaking of your head. The brain is soft. The cranium is super hard and sort of like the moon crust. Congratulations, by the way, on the spaceship going up. I can hardly wait for a ride. To make it to the moon. But that's sort of like what the cranium looks like. It's like all these jagged edges, so you have this soft brain banging against it. And it's not that unusual that you would have cognitive sequela. And people will say, but the X-ray didn't show anything. Well, X-ray is not going to show brain tissue damage. Well, the brain MRI didn't show anything. Well, the brain MRI may not show microscopic changes. So the fact that absence of something doesn't mean that you don't have it. You need to be aware of there's a twisting. Your head could be shifting. You're rarely lined up in a straight line. If you're in a car accident, you're in an impact, chances are there's a bit of an angle and you're not exactly lined up directly 90 degrees perpendicular. So you're going to have a bit of a shearing and tearing. And my point being that you would have neuropsychological sequela, memory issues, problems like that. Also in your field, Raj, with the neck injury, you could have headaches that stem from the cervical, cervical mediated headaches. So I just wanted to bring out to the viewers that you could have several body parts involved with the motor vehicle accident. Having somebody have memory issues, that person could also be having emotional issues. And those are two different kinds of issues that you need to deal with. Puede poner el slide número 12, por favor, Oscar. So here you go, Raj.
Okay, so how do we work up patients. How do we diagnose what is going on? Because before we institute any treatment, we need to diagnose what are the issues. So we spend a great deal of time obtaining a thorough history on a patient, not only what their chief complaints are, but sort of a history of their present illness and how this illness or injury came about, just so we can get as much detail as possible. We also delve into their past medical or surgical history, what current medications they're on, what their social history is like, their vocational history is like. So we spend a great deal of time obtaining a detailed history of the patient, not only as far as their condition, but also as far as what they are as a person as a whole, and their life situation. We then go into a physical examination. For the most part, this entails a thorough musculoskeletal examination, including inspection, palpation, range of motion measurements. We check out motor strength, sensory, reflexes, really do a full musculoskeletal and neurologic exam. That will then help us guide what diagnostic testing needs to be done. And by diagnostic testing, that can mean radiologic studies such as X-rays, CAT scans, MRIs, depending on what's necessary. And then, of course, potentially electrodiagnostic testing, which is a test of the nerves and muscles. There, you may have heard of the term of an EMG. They basically include nerve conduction studies and needle electromyography to help diagnose whether or not there's any nerve disorder, whether it be a pinched nerve in the neck or back or a damage to the nerve anywhere along its course. And then, of course, once we realize our limitations as far as what we can do as physiatrists, we will, of course, then refer to other specialists as well that I talked about previously.
Okay. Oscar, por favor, saca el 12 y pon el 13. We're going to move on to the treatment spot. And then I have some questions after that before we get into some of the psychological pieces.
Yeah. So as far as treatment goes, again, we look at a multidisciplinary form of treatment. We utilize physical therapy, occupational therapy, speech and language therapy. We will utilize certain medications that we have touched upon a few minutes earlier, whether it be anti-inflammatories, muscle relaxants. There is obviously some role for narcotic medications, though a very limited role. And then, of course, there's adjuvant pain medications as well for nerve-related pain. We look at potentially injections, and that can include peripheral joint injections for shoulders and knees that we can do in the office, trigger point injection treatments for tight bands of muscle, and of course, the more high-level injections, especially the spinal injections, we would refer to a pain management specialist for that. Of course, if there is a surgical indication, whether it be an acute surgical indication or surgery because other measures have failed, we would then refer to the appropriate surgeon, whether it be an orthopedic surgeon, spine surgeon, plastic surgeon, vascular surgeon. Again, the psychology intervention, as I said, cannot be understated, just to treat the patient as a whole. And I'll defer that to Dr. Aranda, the expert on the psychological intervention. And then, of course, we look at vocational and avocational training, again, bringing me back to my original point of treating the patient as a whole and knowing how does this injury or illness affect them in other aspects of their life, namely their work, their home life, their recreational life, and we need to address all of those.
Okay. Puedes sacar el slide. I wanted to ask you because it comes up often enough. I think most people are familiar with the term physical therapy, and they sort of take it for granted. Oh, I'm going to go to a physical therapist. I'm being recommended 3 times a week for 8 weeks. You know, a lot of these things are set up by the insurance companies. Different body parts, my right shoulder, my right knee, and some, my lower back. There's going to be, I guess, different ways of doing it. You're not necessarily going to have every body part done the same day. The frequency will vary. But I wanted to ask you if you could explain to the viewers, because this comes up often enough to me, difference between physical therapy and occupational therapy.
Right.
I think they use very.
Absolutely. So the oversimplified way that we talk about this is that physical therapy deals with issues mostly below the waist, and occupational therapy deals with issues above the waist. Again, that is a very oversimplified definition, but the physical therapist will tend to work on lower extremity disorders as far as gait, ambulation training, mobility training, but they will also work on patients that have shoulder issues as far as use of certain modalities, heat, cold, ultrasound, electrical stimulation, soft tissue massage, range of motion and strengthening exercises. So they handle more of the musculoskeletal issues related to whatever body part is involved. The occupational therapists deal more with upper extremity disorders that involve gross and fine motor movement, and also concentrate on assisting patients and helping them gain independence with regards to their activities of daily living. I touched on that term, activities of daily living. We have what's called our basic activities of daily living, which are things like dressing, bathing, grooming, personal hygiene, and then our instrumental activities of daily living, which is ability to sort out groceries, or balance a checkbook, to be able to figure out how to use public transportation. So the physical therapists deal more with gait and mobility issues, as well as range of motion strengthening exercises for primarily the lowers, but the upper extremities as well. And the occupational therapists have a focus more so on activities of daily living training.
Right, things like being able to button your shirt, zip and unzip your pants, open up containers, unscrew things, put things into a box. Those kinds of movements that you need, the fine motor of the fingers,
exactly.
Strengthening so that you don't drop things all the time.
Right.
So that would be more the OT. Okay, so let's move on, por favor, Oscar, el número 14. We're going to go through the next two a little bit more quickly because we already touched on some of the things psychologists do. So basically, está el número 14? Okay, so, things that psychologists do, evaluations, emotional, physical, cognitive complaints, or, things pertaining to like your thinking, memory, behavioral changes, like you don't want to drive, you don't want to go to bed, you don't go outside, your intimacy has changed with your spouse. Physical, you can't go up and down stairs. Emotional, I'm depressed, I'm anxious, I don't feel like doing anything. Consequences of physical injuries and chronic pain. So we're focused. This obviously overlaps a lot with what Raj was talking. Loss of function, changes in lifestyle, the activities of daily living as an example. A person isn't able to work as before, isn't able to drive as before, can't go for walks like before, isn't able to dress without assistance or shower without assistance. The effects of trauma, some of the traumatic, the car accident can leave you phobic. Some of the occupational injuries can as well. You need to coordinate treatment needs, consult with and refer to other specialists. Similar to what Raj was saying, I would initiate and make referrals to other areas of expertise. Provide psychological treatment geared to developing coping skills and restoring pre-accident functioning as best as possible. For me, the goal is you're injured. I have to consider what your limitations are. If I'm getting an estimate that like the best you're going to recover from your hand injury is 80%, well, I'm not going to aim for 100%. It's not going to work. So you need to consider, given what we have post-accident, what's reasonable. Let's use that as your new baseline and let's move forward. Consult with family members if and as needed. Testify as needed. I've alluded to this. Comply with workers' compensation regulations as required. No fault also has requirements. And insurance companies, private insurance carriers also, well, they're going to have their requirement. Specialized intervention, being supportive, dealing with pain, stress management, relaxation training. I've covered a lot of this many times in other shows. Cognitive behavioral therapy, modifying the way you think, modifying some of your behaviors, and contracting with the patient, like for instance, who may have been exposed to an accident and is afraid to go out. Well, let me try to get you out for 5 minutes. Let me try to get you into a car with your spouse. Just sit in the car. Something trying to get them to move in a positive direction. That would be in cognitive restructuring, modifying your crazy thoughts, modifying misbeliefs. I'm useless. I'm helpless. Things are never going to work for me. I'm not going to be the same I was before. Well, how do you know this? That's bad baggage. You don't want to carry this bad baggage with you forever. Por favor, Oscar, saque eso y pone el número 15. These are some treatment approaches. Again, like Raj, I agree with the team approach. Cognitive behavior therapy, I already mentioned it. Relaxation therapy, there's many different kinds. Meditation, hypnosis, biofeedback. Problem-solving therapy, you have a problem. What are some ways that you think you can address that problem? How do you envision your solution? Let's discuss it. Let's focus on it. Let's eliminate things that seem to be really out of your reach versus that which makes some sort of sense. Even if you don't like it, you may not be happy, but your best solution, it may be something that you need to work on, even if you are not happy about it. So let's do some talking about it. Cognitive restructuring, again, modifying the faulty thinking. Thought stopping, quiet, enough. Turn that dialogue off in your brain. Change the chatter in your brain. Focus on something else. Put music on. Get up. Wash your face. Make a phone call. Desensitization, exposure. You're afraid to drive. Let's get you into a car. No driving. Let's get you to drive around the block. Let's avoid driving in the dark, in the rain, and in inclement weather, and stop and go traffic, and on highways. Let's do it step by step, baby steps, I guess would be a good way to put it. Behavioral contracting, what I just mentioned. Have somebody go out for 5 minutes. You're afraid to be outside. Go outside for 5 minutes before you come back home. Stay outside for an extra 5 minutes just to show that you can control it. Then go back home. Homework assignments. I give people tasks to do. What is it that you can do? Work on this exercise. Work on that exercise. Work on your relaxation exercise. Work on talking to your doctor. Work on writing a list of what your complaints are. Work on writing a list of words so you can memorize them. That's the memory exercises. Teletherapy, this has become super popular, especially after COVID. Basically, it's virtual, telephone and or video kinds of consultations. Puedes sacar el slide. I said a lot there. Raj, anything to add to that psychological? I wanted also to add that there are instances that I have been asked to do evaluations for spinal cord stimulator implants for the trial, then for the permanent one. There are other kinds of procedures, bariatric surgery, for instance, that require some psychological intervention ahead of time. Anything to add to that before we go to the last slide?
No, that was a very, very comprehensive list of all you do, and we're certainly most appreciative of it.
All right, por favor, Oscar, el número 16, el 16, dear viewers, this is our last slide. And I just wanted to bring to your attention again, I'm top left, my consultant, Dr. Canaris, top right. Dr. Tolad, I gave his phone number. This is an office for Medford. Did you have anything that you wanted to add to that?
Yeah, I'm just going to verbally give out my phone number for my office in Valley Stream, which is called Premier Physical Medicine and Rehabilitation. And the office number is 516-593-3030. Again, 516-593-3030. And my office number for my office in Belrose is 718-343-6300. Again, that's 718-343-6300.
But of course, the number that I put there, people can just jot that down, call, and be referred to the appropriate location.
Absolutely.
Okay. Beneath that, New York State Psychological Association, their address and phone number and website. American Psychological Association, you've heard me mention this many times before, the parent organization of all state and provincial psychological associations. I live in Suffolk County, so Suffolk County Psychological Association. I'm always delighted to mention them and support them. Westchester, I've had some dealings with Westchester. It's just north of Manhattan. And I gave you a list here of the regional psychological associations with the website. Puedes sacar a slide. I encourage my viewers to, make screenshots by tomorrow if you didn't take photographs. We're pretty much wrapping. So, Dr. Tolat, any parting comments to the viewers as we wrap up?
Well, I'd just like everyone to know that we're out here to support you and to help you. And if there's anything that we can do to help you overcome an injury or an illness, please don't hesitate to contact.
Well, thank you. You've been a delightful guest. I've learned a lot. Your expertise amazes me, and I'm so glad that you accepted my invitation to be a presenter today.
Well, thank you for having me on your show.
There's a lot. There's so much material that we went over that I know for a show of about an hour and 15 minutes or so, it's really difficult to digest it all. Which is why I encourage the viewers to take the screenshots. But I agree with the team approach. It's so important. Oscar, ¿alguna despedida? Oscar, once again, have a happy Thanksgiving. And for me, it was a delight to have Raj Tolat as my guest. I did want to ask all my viewers that basically, again, feel free to take screenshots. Be careful, be safe outside. Please continue to maintain some proper precautions. You have flu, you have COVID, you have other bad bugs that are out there. Be careful on the road. The accidents do happen, as you can see. You're dealing with drivers that may be impatient, bad weather conditions, weather changes. Be careful on the outside. Be aware of your neighbors and be aware of the community. Look out for one another. Recognize that if you need some assistance, contact me, contact Dr. Canaris, contact your whoever else you may be inclined to speak to, a trusted family member, friend, or peer. Don't rely on social media as your main sources of advice and information, really. If you have religious beliefs, that's wonderful too. My message, and I believe Dr. Tolat will support it, is that even in the event of accidents, there's always an opportunity to improve. There's always light at the end of the tunnel. There's always things you can do to improve your lifestyle, to go forward, to make things better. Don't get in a rut. Don't get stuck. Don't give up. Don't develop that helpless, hopeless, I am depressed, I don't want to do anything attitude. That is just horrible. Again, there's something positive for everybody, and that's really what I want to focus